Good morning, students. Today's the class is on gingival enlargement. What is a gingival enlargement? The gingiva and the associated soft tissue of the periodontium may be enlarged in response to various interactions between the host and the environment. Although such enlargement usually represents an inflammatory response to bacterial plaque, increased susceptibility as a result of systemic factors or conditions should always be considered during the course of patient evaluation. So the gingival enlargement happens when there is a bacterial plaque uh, which causes an inflammatory response, or it increases the susceptibility due associated with the systemic factors or conditions. Gingival enlargement is also called as increase in size of gingiva or gingival overgrowth. The classification, we have two types of classification. One is according to etiological and pathological changes, according to location and distribution. According to etiological and pathological changes, the enlargement is further classified as inflammatory enlargement, drug-induced enlargement, enlargement associated with systemic diseases or conditions, systemic diseases, neoplastic enlargement, false enlargement. In inflammatory enlargement, we have chronic inflammatory enlargement and acute inflammatory enlargement. In drug-induced enlargement, we have anticonvulsant causing enlargement, immunosuppressants causing enlargement, and calcium channels causing enlargement. And condition enlargement, we have pregnancy enlargement, puberty enlargement, vitamin C deficiency, plasma cell gingivitis, and non-specific condition enlargement like pyogenic granuloma. Systemic diseases causing general enlargement, we have leukemia and we have granulomatous diseases. Apart from this, we have neoplastic enlargement, which is benign enlargement and malignant enlargement. And last is false enlargement. And Schaefer has a other classification in which he classified as inflammatory gingival hyperplasia, non-inflammatory gingival hyperplasia, and combination of inflammatory and fibrous hyperplasia. And Carranza gave another classification based on location and general distribution as localized, generalized, marginal, papillary, diffuse, and discrete. How do we classify based on the location? Gingival enlargement has been classified based on location as localized, generalized, marginal, papillary, diffuse, and discrete. You can see a localized enlargement which is confined to one of the tooth, and generalized which is confined to all the tooth. Marginal gingiva is also similar to that of localized, which involves only the location, the margin of the gingiva, and papillary enlargement, which involves the interdental papilla. And diffuse, we can see both marginal and papillary getting involved, and discrete, one certain point of the gingiva getting enlarged. So, according to its location and distribution, it is classified as localized, generalized, marginal, papillary, diffuse, and discrete. Next, we have the scoring for gingival enlargement. We have grade 0 to grade 3. Grade 0 is no signs of gingival enlargement. Grade 1 is enlargement confined to the interdental papilla. Grade 2 is enlargement involves the papilla and the marginal gingiva. And the grade 3 is enlargement covers 3/4 or more of the crown. Next, we see the inflammatory enlargement. Inflammatory enlargement can be classified as chronic and acute. We have chronic inflammatory enlargement is more common, and it is secondary complication of a systemic disease. The etiology is prolonged exposure to dental plaque, maybe reason of a poor oral hygiene, malocclusion, hypofunction, cervical cavities, overhanging margins, irritation from a clasp of a denture, or a nasal obstruction, or a mouth breathing. So we classify the gingival inflammatory enlargement as chronic inflammatory enlargement and acute inflammatory enlargement. We can see the clinical features of chronic enlargement as ballooning of interdental papilla and marginal gingiva. It is localized or generalized, progressive, slowly, and painless. Situs usually affects the interdental papilla, marginal, and attached gingiva. Etiology is prolonged exposure of dental plaque, poor oral hygiene, anatomical abnormalities, improper restorative and orthodontic appliances. Next, we see the acute inflammatory enlargement, which is known as gingival abscess, which has a clinical picture of localized, painful, rapidly expanding lesions. Lesion which becomes fluctuant and pointed with surface orifice within 24 to 48 hours. Site is limited to marginal gingiva or interdental papilla, and the bacteria carry deep into the tissue with the foreign substances forcefully being embedded into the gingiva causes this type of enlargement. Usually a food particle, usually a food or a plaque which accumulates between the gingival and gingiva is the reason for the gingival abscess. See, this is how the progression of the gingival enlargement happens. We see about detail about the chronic inflammatory enlargement. Clinical features. It originates as a slight ballooning of the interdental papilla or the marginal gingiva. Early stages, it produces a life preserver shaped bulge around the involved tooth and slowly and painlessly progresses to an acute infection and a trauma. Due to an acute infection or trauma, it is described discrete sessile or pedunculated mass resembling a tumor may undergo spontaneous reduction in size followed by exacerbation and ulceration. So it progresses with the exacerbation and ulceration. So histopathological features we can see inflammatory cells. Inflammatory cells infiltrate with vascular enlargement, capillary formation, and associated degenerative changes are seen in the histopathological pictures. So main reason for the chronic gingival enlargement is due to mouth breathing. In mouth breathing, we can see a red and edematous with a diffuse surface sinus of the exposed area. The usually affected area is maxillary anterior region is the common site of enlargement. Next, we see about the acute inflammatory enlargement. It is a gingival abscess. Gingival abscess is localized, painful, rapidly expanding lesion with a sudden onset. Early lesion shows red swelling with smooth, shiny surfaces, fluctuant, pointed on surface, and burst. Sometimes adjacent teeth also sensitive. Etiology is foreign substances, tooth bristles, a piece of food particle like apple core or a, or a lobster or a shell fragment can cause a gingival abscess. Histologically, you can see purulent focus surrounded with inflammatory cells. We can see both inflammatory cells as well as some purulent cells. Next, we go about the important thing is drug-induced gingival enlargement, which is a commonly asked question, which comes in the 5 marks or an essay associated with a question. So you can see a drastic gingival enlargement, which is more abnormal than an inflammatory enlargement. Main drugs which causes enlargements are antiepileptics, immunosuppressants, dihydropyridines, NSAIDs, hormonal drug, and some miscellaneous drug. So drugs which causes overgrowth are simply classified as three classes. One is anticonvulsants, immunosuppressants, and calcium channel blockers. What are the general features of a drug-induced enlargement? Drug-induced enlargement starts as a painless, bead-like enlargement of the interdental papilla. As the condition progresses, the marginal and the papillary enlargement unite and results in a massive tissue fold covering most part of the crown. When uncomplicated by the inflammation, the lesion is mulberry-shaped, firm, pale, pink, and resilient with a minutely lobulated surface and no tendency to bleed. You can see a mulberry picture. Similar to the mulberry picture, we can see an enlargement, which is usually a bead-like enlargement around the interdental papilla, but slowly it progresses to the marginal gingiva also, causing a complete enlargement. So, classification of gingival hyperplasia caused by dilantin. Grade 1 is minimal, no hyperplasia. Grade 2 is moderate, definite hyperplasia of gingiva with a re-encroachment on the clinical crown of the teeth but no interference of the function. And grade 3 is severe, which interfere with the function due to overgrowth. So the enlargement of drug-induced is classified as grade 1, grade 2, and grade 3. Histological classification, we have no grade 1, which is normal gingiva. The width of epithelium is around 0.3 to 0.5 mm. And grade 2, it's a slight overgrowth. The width of epithelium will be 0.5 to 1.5 mm. Grade 3 is moderate growth. The width of epithelium is 1.5 to 3 mm. Grade 4 is severe overgrowth. The width of epithelium is 3 to 4 mm. And we have another classification of gingival enlargement. The degree of gingival thickening on both labial and lingual surface was classified. So when we want to classify on the two surface, one is buccal, and usually the all the enlargement was classified on the buccal surface. We want to classify it on the both labial and lingual aspect. We have the Seymour Smith and Turner classification, which classified as 0, which is normal, and 1 thickening from the normal up to 2 mm, and 2 is thickening from the normal greater than 2 mm. So coming to the drug-induced gingival overgrowth, we have three types of drug, as I previously described. One is anticonvulsant, two is calcium channel blockers, third is immunosuppressants. The main anticonvulsant drugs are phenytoin, valproic acid, vigabatrin, and the calcium channel blockers are antihypertensive drugs of for angina of peripheral vascular tissue. Usually they are nifedipine, diltiazem, verapamil, amlodipine, felodipine. And immunosuppressant, we have cyclosporin for prevention of, usually given for prevention of transplant rejection, autoimmune like rheumatoid arthritis, limited to renal and cardiac and gingival fibrosis. Immunosuppressants. It is a dose dependent and frequently reversible. It causes gingival overgrowth, nephrotoxicity and weight gain, and hepatotoxicity, hypertension, hyperuricemia, mild anemia, neurotoxicity, visual disturbances, hypertrichosis, trachyonimus, adverse effects to a lesser extent. Incidence is 25% of renal transplant cases, 38% of cardiac transplant, 37% of liver transplant. We give this drug. Next is calcium channel blockers. You can see the picture of a calcium channel blockers causing a enlargement. Next is sex hormones and oral contraceptives, most widely used. Mostly a combined preparation of estrogen and progesterone resolves when drug is withdrawn, appears to be a secondary reaction to the presence of local factors. Estrogen increases the keratinization of already keratinized tissue, mucosal tissue, or increased. Tendency to overgrowth, increased activity of the epithelial cells are seen. In non-epithelial tissue, increase in mucopolysaccharide content is observed. Progesterone increase the permeability of gingival vasculature. Factors plays a role in pathogenesis of the drug-induced gingival enlargement of age, genetic predisposition, pharmacokinetic variables, drug-induced alteration in the gingival connective tissue hemostasis, drug-induced action on growth or factors. Next, we see about the enlargement associated with systemic disease. When a magnification of the existing inflammation is caused by condition enlargement, manifestation of systemic disease independent of gingival inflammation, inflammatory diseases such as systemic diseases causing gingival enlargement and neoplastic enlargement. So we see about the condition enlargement. When we see about the condition enlargement, we have hormonal enlargement, nutritional attachment, and vitamin C deficiency. When we see about the enlargement in pregnancy, it is also called angiogranuloma, may be marginal or generalized or single or multiple tumor-like masses The usual drug is progesterone and estrogen. These hormonal changes induce changes to the vascular permeability, leading to the gingival edema and an increased inflammatory response to the dental plaque. The subgingival microbiota may also undergo changes, including an increase in Prevotella intermedia. Marginal enlargement in pregnancy. Aggravation of the previous inflammation. Incidence has been reported as 10% to 70%. Clinical pictures, it varies considerably, generalized and more prominent interproximally than on the facial and the lingual surface. Enlarged gingiva is bright red or magenta, soft and friable, and has a smooth, shiny surface. The bleeding occurs spontaneously or on slight provocation. Tumor-like gingival enlargement. It is not a neoplasm. It is an inflammatory response to bacterial plaque modified by patient condition. Usually appears after the third month of pregnancy. Reported incidence is 1.8 to 5%. The lesion appears as a discrete mushroom-like flattened spherical mass protrude from the gingival margin or commonly from the interproximal space and are attached by a sessile alpha-triangulated tissue. Next, we see the enlargement in puberty. Both male and female adolescents, we can see, appears in areas of plaque accumulation. Often, only the facial gingiva are enlarged with lingual surfaces relatively unaltered because of the mechanical action of the tongue. After puberty, the enlargement undergoes spontaneous reduction but does not disappear until plaque and calculus are removed. Enlargement in vitamin C deficiency is one of the important condition, which is classical description of a scurvy. Such enlargement is essentially a conditioned response to bacterial plaque. Acute vitamin C deficiency causes hemorrhage, collagen degeneration, and edema of the gingival connective tissue. The clinical features is it involves a marginal gingiva. We can see a marginal gingival enlargement. The gingiva is bluish red, soft and friable, and has a smooth, shiny surface. Hemorrhage occurring spontaneously or on slight provocation. Histological features, we have a surface necrosis with pseudomembrane, chronic inflammatory cellular infiltration, and scattered areas of hemorrhage also seen with engorged capillaries. Marked diffuse edema, degeneration, and scarcity of collagen fibrils or fibroblasts are striking findings. Next, we see about a condition enlargement is plasma cell gingivitis. It is an atypical gingivitis and the plasma cell gingivitis consists of a mild marginal gingival enlargement that extends to the attached gingiva. It is allergic in origin and we can see a plasma cell granuloma, localized lesion. Gingiva appears red, friable and sometimes granular and bleeds easily. No attachment loss is usually occurs, located in the oral aspects of the attached gingiva, and associated cheilitis or a glossitis has been reported. Plasma cell gingivitis is thought to be allergic in origin. Next, we see about the non-specific condition enlargement. Non-specific condition enlargement is pyogenic granuloma, tumor-like gingival enlargement that is considered as an exaggerated condition response to minor trauma. So when we have a trauma, we can get this pyogenic enlargement. The exact nature of the systemic condition factor has not been identified, although the clinical features is discrete spherical tumor-like mass with a pedunculated attachment to a flattened base or a killer-like enlargement with a broad base. It involves spontaneously to become a fibroepithelial papilloma or persists relatively unchanged for years. Treatment consists of removal of the lesion plus the elimination of the irritating factor. The recurrence rate is about 5 to 15%. Next, we see about the systemic diseases causing the gingival enlargement. Next is leukemia, diffuse or marginal, localized or generalized, and oversized extension of the marginal gingiva, a discrete tumor-like interproximal mass, generalized bluish red and has a shiny surface, moderately firm, but there is a tendency towards friability and hemorrhage, occurring either spontaneously or on slight irritation. It is associated with chronic inflammation. True leukemic enlargements occur commonly in acute leukemia, but may also seen in subacute leukemia. Next, we see the granulomatous diseases. Weakness granulomatous. It is a rare disease characterized by acute granulomatous necrotizing lesion of the respiratory tract, including nasal and oral defects. Cause not known. Immunologically mediated tissue injury. Clinical features reddish, purple, and bleeds easily on stimulation. Sarcoidosis. It is a granulomatous disease of unknown etiology. Starts in individual in their 20s or 30s. Affects predominantly black and can involve almost any organ. In gingiva, it is seen as red, smooth, painless enlargement. We can see. Next is neoplastic enlargement. We have two types. We have benign and we have one is benign, another is malignant. Benign lesion, you can see in fibroma, papilloma, peripheral giant cell granuloma, central giant cell plasmoma. Others we can see as nevus, myoblastoma, hemangioma, neuruloma, neurofibroma, mucosals, and ameloblastoma. Malignance is caused by carcinoma. We have squamous cell carcinoma and malignant melanoma. Sarcoma, we have fibrosarcoma, lymphosarcoma, reticulum cell sarcoma, and Kaposi sarcoma. Next, we go about the false enlargement. So, it is a non-true enlargement of the gingival tissue, appears as a result of increase in size of underlying osseous or dental tissues. The gingiva usually represent with no abnormalities, clinical features except the massive increase in size of the area, underlying osseous lesions, examples of tori and exostosis, Paget's disease, fibrous dysplasia, cerebrism, ameloblastoma. The underlying developmental tissues, examples development enlargement seen in primary dentition. So we can see next about the treatment. What we have seen is what is gingival enlargement, what are the etiology, what are the classifications, how do you classify a gingival enlargement, and we see about the specifically about the drug-induced gingival enlargement. What are the various drugs which causes the gingival enlargement? Next, we see about the conditioned enlargement. We see about the systemic factors causing gingival enlargement, and we see a neoplastic enlargements, and we can see the false enlargement. So these are the various types of enlargement. And then we see about the in all the enlargements we see about the clinical features. How does it enlarge? Then we can be seen about the histopathological features associated with the enlargement. Now, next is the treatment. Treatment of gingival enlargement is based on understanding of the cause and the underlying pathological changes. When we do a treatment for a chronic inflammatory enlargement, we do scaling and root planning. It's fibrotic component that does not undergo shrinkage after scaling and root planning. Surgical removal is treatment of choice. We two techniques is gingivectomy and flap operation. A soft and friable even after SRP. Gingivectomy is the treatment. Mostly for gingival chronic enlargement, we do a scaling and root planning. We remove the cause. If it is persist and if this fibrous tissue is persistent, then we go for a gingivectomy. We see about the abscesses. We have patient general systemic response to be evaluated. Rise in temperature, fever, and feeling of malaise should be noted, and proper antibiotic regimen should be started. And then we have to do a drainage. Drainage established through the pocket or through external incision. When we see about the treatment for gingival abscess, it's a simple drainage. We can use a warm saline gargle. If residual size is too great, we can remove surgically. And the treatment of choice is periodontal abscesses, adequate drainage and antibiotic. Chronic periodontal abscesses, adequate drainage and antibiotic treatment. When we see about the drug-induced gingival enlargement, we have to first see about the discontinuation of changing a substitution with a suitable alternative. 1 to 8 weeks for resolution of gingival enlargement. Unfortunately, not all patients respond to the mode of treatment, especially those with long-standing gingival enlargement. Second, the clinical should emphasize plaque control as the first step in the treatment of drug-induced enlargement. Third, if the gingival enlargement persists after the consideration of above mentioned approaches, the cases needed to be doing a surgery, that is gingivectomy or periodontal. So when we do go for a surgery, we have three modes of surgery. We have a conventional method where we use a gingivectomy knives, scalpel, and electrosurgeries units, and we have lasers to do the gingival enlargement using gingivectomy. When we see about the leukemic gingival enlargement, mostly with subacute and acute cases, rarely with chronic, we have to get a consultation with a patient physician and hematologist. Superficial scaling can be done, localized area under topical anesthesia, and we have to manage the bleeding. Progressive deeper scaling is done in subsequent visit. We will see the how the initial response is happening. Then we can go for a systemic antibiotic coverage. What are the treatment for pregnancy, gingival enlargement in pregnancy? We have to eliminate a local irritants and marginal interdental inflammation are treated by scaling and curettage. And treatment of tumor-like enlargement consists of surgical incision and SRP. We have to do a gingivectomy. Lesion should be removed surgically during pregnancy only if they interfere with the mastication. We should not touch otherwise with mastication or produce aesthetic disfigurement that the patient wishes to remove. Thank you. So, in this chapter, the important questions are what define gingival enlargement? What are the other names for gingival enlargement? We have other names like gingival overgrowth or increasing size of gingiva. Then we know we have to see about the types of gingival enlargement. We have the location wise classification. We have location wise classification, and we have the types of inflammatory enlargement. We have drug induced enlargement. We have conditioned enlargement. We have leukemic enlargement and false enlargement. So we have seen about all the enlargements and the classification and the treatment plan in this class. Thank you.